What a great treat to be here, and Mehmet, thank you. Special thanks to the Cura Foundation, to all the sponsors, but I wanted to take a minute because I'm probably the only one on the planet who could tell the real story of why we're here today. So I've been at Jefferson University in Center City, Philadelphia for 28 years as a faculty member. 3 years on into my tenure as a young assistant professor of medicine, a beautiful, incredibly smart, but somewhat stricken junior trainee resident named Robin Smith came to my office. This is 25 years ago. And Robin said, "I don't really know what you do, but it sounds like what I want to do, and therefore you will be my mentor." So how about a special round of applause for this special lady?
And she was only 9 years old at the time, which is really remarkable.
Right. That's exactly right. So I also, a number of years before that, I had a Wharton professor, which is so prophetic for today, who said to me, you know, David, always be nice to people on their way up. You may need them on your way down. And here we are in Rome. So that's my special introduction. So really great to be a part of this, and I'm going to be very, very quick. My job today, as Mehmet has so nicely elucidated, and fantastic leaders who are here with me, and the previous speakers, a new medical school. So I'm very, very privileged to be leading the country's first college called a College of Population Health. What exactly is that? I'll show you in a moment. So I'm really going to leave you with 4 things, and then I'll show you some fun slides that'll reinforce the main points. So first, I'm going to describe one college devoted to the study of population health, and as Mehmet alluded to, population health intelligence. In fact, it's a term we've trademarked. And yesterday, you heard some of the most famous people in the world, literally, talking about big data, population health, analytics, predictive analytics. We're putting all of that under the umbrella of this new term, population health intelligence, which is to glean better information about health, not about healthcare services, but about health. More about that in a moment. My second goal is really to help you to grasp what this term is all about, describe our school, give you one take-home message, and then I'd like to issue a challenge to this incredible global audience, which is to join with us in the journey. One college and 6 or 7 more that are under construction, a new medical school, as you heard at Hackensack. These are the beginnings, I think, of a brand new movement. So let me show you what I mean, and hopefully we'll get the slides to go. So Jefferson is in Philadelphia, not in Virginia. We're a 14-hospital system. We have 9 colleges. I have the privilege of leading one of these, and it's the smallest and newest of the 9, called the College of Population Health. Why do we need such a school? So for folks who are from the great country of the United States and looking at this report from the National Academy of Medicine 2013, it's no surprise to this sophisticated group, our country spends more money on healthcare, $3 trillion, than any other nation on the planet, and we're number 17 in the world with regard to the health and well-being of our population. So we spend the most, and we're not in the top 10 measure of any measure publicly available with research behind it that describes how healthy we are. I think this is a great picture, and it's Sanjay Gupta there in the middle, balancing between these 2 canoes. And one canoe, the one on your left of a private practice fee-for-service, the more we do, the better we are. And the one on your right, the canoe that I think this part of this fantastic conference is all about, population health. And that's the canoe that we all have to get in, and I'm going to leave you with some pithy ways of remembering it. So I think our movement had a watershed event just a little over a year or so ago in the country's most important medical journal, USA Today, page 1 story that sort of said, hey, wait a minute, it's not about getting heads in beds and filling all the 14 hospital beds that make up Jefferson Health. It's all about how do we keep people, in fact, out of the hospital. It's a total paradigm shift. Not easy in a city like Philadelphia with 5 medical schools. How are we going to change this entire model? And I've got 2 great colleagues up here who are going to give you much more of the detail. But I think one take-home message is we have to totally change the model, turn it upside down completely. How are we going to do that? Well, David Kindig, one of our colleagues, still alive, working great at University of Wisconsin, 2003 paper, 15 years ago, said, hey, public health is pretty darn important. AIDS reduction, smoking cessation, reduced weight, vaccination, clean water. Public health has done more to improve health than America's 140 medical schools any day of the week. But what population health is all about is all those things, and it adds 2 other issues. Are we delivering care that's safe and effective? Pretty darn important. And what does it cost? So we built this College of Population Health using this framework from this now classic 2003 paper. And then around that, we've added the notion that, hey, it's a lot about what Mehmet's been talking about. Individual behavior is what makes us healthy. Where we live is what contributes to making us healthy. Access to medical care, that's about 10 or 20% of the issue. But on your right, in Philadelphia, it's awfully inconvenient if you have to walk more than 2 blocks to get a cardiac catheterization, because we have so many hospitals, so many beds, and yet our city is, compared to the rest of the state, very unhealthy. So it raises some difficult ethical issues. What's the real mission that we're a part of? In any event, lots of smart people, including the National Academy of Medicine, have been writing about this. I'm not going to spend our limited time today. I hope you'll all read Vital Directions. We're very privileged to have some former presidents of the National Academy of Medicine here in the audience. This most recent book from them, I think, is really, really important and is a great background book to what population health and population health intelligence are all about. If you look at page 240 in your prayer books that we were given, this amazing, amazing book, and on page 240 is a brief description of who we are and what we're about. So I didn't come here to advertise, but let me give you what the punchline is. So we believe, as do lots of smart people at the British news magazine, The Economist, it's all going to be about the data that we're going to collect from patients. Let me give you a specific example. So Mehmet's a clinician, Glenn's a clinician. Now we're going to start asking, hey, could you afford the medicine and the prescription we gave you? Hey, could you get a ride to the office? Hey, do you have a refrigerator at home to keep your medicine in? Could you imagine us beginning to ask these kinds of questions? Colleagues, the most important 2 numbers I need to know about you to predict your lifespan is not your cholesterol, although that's interesting, not your blood pressure, it's your zip code and your credit score. If I know your zip code and credit score, I got pretty good idea how long you're going to live. And in Philadelphia, 4 miles apart is a lifetime disparity of 20 years. You grow up in Society Hill, you're going to live to 88. You get in a car, go up 4 miles north on Broad Street, life expectancy 68. It's all about big data, predictive analytics, zip code, credit score, or what we like to call now population health intelligence. So here's the challenge. I hope you'll join us. All our work is at the graduate level only. It's exclusively online. I'd love to have everybody in this audience contributing, writing, being a part of the movement. Here is our peer-reviewed journal. Let me show you what it looks like. So this is specifically in our field called Population Health Management. We have editorial board members all over the world. We meet annually in Philadelphia. I'd love to have all the brain power that's here in this room be a part of that. So let me end with the take-home message. To be a part of this fantastic conference, truly, what an amazing privilege. So we believe it's all about transparency and accountability of the data. Mehmet, that's what population health intelligence is really about. And at the end of the day, I think the easy way to remember what we're trying to promulgate here is no outcome, no income. If we can't improve health, we ought not to get paid. That is really going to be the paradigm shift that we believe population health intelligence is going to promote. Thanks so much.
You know, David, you should have your own talk show.
There you go.
You guys be Deb, take it away.
Thank you, David. So now I'm going to call it, I was going to say I'm going to tell 3 stories about big data and analytics, but now I'm going to tell 3 stories about population health intelligence.
There you go. Excellent. I got one recruit.
Is what we're going to do. All right. Okay. So the first chart here is exactly what David was saying. It is exactly what we actually have been talking about for the past couple of days, that your health determinants are actually only 10% of your clinical factors, 20% of your genetic factors, and 70% of your zip code and your credit score. So I don't have to elaborate on that. I want to tell 3 stories, and we'll go backwards, of what is actually being done. So in big data and analytics applied to population health. So the first is IBM Watson Health's partnership with Medtronic. And we created this diabetes app. We heard about diabetes yesterday. We created this diabetes app called Sugar.IQ. A couple of things about this app. First of all, I'm going to tell you about the algorithm in a minute, but it took us 10 weeks to create the algorithm. It took us about 3 months to get the app in the shape it's in, and it took Medtronic a good chunk of time to get FDA approval for the entire system, which includes their continuous glucose monitor, the insulin pump, and the app. But the good news is that we now have FDA approval, and starting in June, we will be marketing it. The app is called Sugar.IQ. We did something very hard with Sugar.IQ. We took 600, then 2,000, then 10,000 of Medtronic's patients and their data from their CareLink app. And with that, we created an algorithm using deep learning artificial intelligence, that was asked yesterday, to predict the onset of a hypoglycemic event. And we were able to, now with over 93% accuracy, predict the onset of a hypoglycemic event 3 hours before it happens. If you're a type 1 diabetic, that is very huge. That is very huge. So we thought that was the hard part, and we thought that that would make the most difference. But we did other things with the app as well. We track where they live. We do track their credit score. We do track where they walk, what they eat, what they do. We put it all into an app that you see in the right here with the little text box, gives prompts to the patient of, we notice that when you wake up in the morning, your blood sugar is low, get up and walk. This usually works for you. We track here with the circle at how much time during the day they're actually in their proper glucose range. We track based on what they eat, what's happening to their blood sugar in the bottom. And we did something very, very simple, and we put it in at the end, right before we were going to release the app for the clinical trial. We put in, would you like to follow your favorite foods? We threw it in at the end, gamification. Would you like to follow your favorite foods? So 250 patients tested in the clinical trial, and what we found was that, in fact, the patients using the app were able to stay within their glucose range 37 minutes more per day. That is, you heard yesterday that on average, people only stay in it for half of their day, so 37 minutes more makes a difference. And 65% of the patients had fewer lows, and 55% of the patients had fewer highs. 78% of the patients logged their foods. And this is what we found. Of the patients who logged their foods, we saw an immediate improvement in, I know we said yesterday we don't like patient compliance, but we saw an immediate improvement in patient compliance. And it was amazing to see the foods that they tracked. Take a guess, please. Just yell it out of what you think the #1 food these type 1 diabetics tracked to see, would you like to follow your foods and know what happens to your blood sugar? Pizza, close. It was Dunkin' Donuts. So I don't know, but I'm thinking I'm a type 1 diabetic. I'm going to know that eating that jelly-filled is going to affect my blood sugar. The top 5 were Panera, cornflakes, ice cream, and buttermilk biscuits. Glenn and I were talking before, and I said we saw more than anything else we do, more than all the smart things we do with our artificial intelligence algorithms, simply letting them follow their food. We saw, and it's immediate. You eat the Dunkin' Donuts, and then within 5 minutes, you're seeing what's happening to your blood sugar up here on the top. And so we saw an immediate behavioral impact. All right, that's story number one: big data analytics, population health intelligence, and helping patients with their type 1 diabetes. My next story is in Bolzano, Italy. How many of you know Bolzano? It's a beautiful, beautiful place. It is also the place on Earth that has more people over the age of 65, the city. I think Japan is the country with more people over the age of 65 anywhere else, but this city has more people over the age of 65 than anywhere else on Earth. 1 in 5 of the population are now over the age of 65. There are 3 people over the age of 65 for every 2 people that are under the age of 20. It is not only a health crisis, but it was an economic problem for the city because they were spending 76 million euros to manage the social programs, and 42% of that 76 million were going to aging populations. And so here's what we did. Sounds a little scary, but it really made a tremendous impact both in health and in expenses. We put sensors in the apartments, water sensors, electricity sensors, and sensors on the door. We could then track, is the water being used? Are people using the water to go to the bathroom, to make the pasta? Is electricity being used? Are people waking up when they typically wake up? There's sensors in the bed to know if they have fallen out of the bed or if they've gone to sleep. There's sensors to understand if they were doing their sewing. And then we had also health sensors around various health sensors. The sensors are important, but what's more important is finding the repeatable patterns of when an individual typically does get up, brush their teeth, make their pasta, do their sewing. We also connected them via social network. And what we found was that the patients, the people really did get more connected. So we saw depression go down, and we were able to create patterns and then alert social services or the families if they needed to be called. What we found was that the rates of depression went down, the rates of crashing and going into the hospital went down, and there was a 30% savings in assistance due to the care that we were given, showing that you really can make a difference in population health intelligence. And it might sound very, very intrusive to have your electricity and water monitored, but versus my Auntie Teresa, who walked out of her home when she was 81 years old in her house dress to go get on a bus. I wish that the door had sensors on it so we could have been alerted. And then my final story then is on using population health intelligence in really a completely different environment. We call this Watson Care Manager, and it's used in a variety of settings, but I just want to talk about it in the drug courts. So Watson Care Manager is used in drug courts all over the United States, 30 drug courts. And what we do is if you're in a juvenile drug court, the judge has 6 to 7 minutes to talk to the child and their family and evaluate what needs to be done and give his judgment of what should be done with this child. 6 to 7 minutes. Associated with this are 400 to 500 pieces of paper talking about the health of the child, the incarceration of the child, the schooling of the child, if they have a job. What we do is artificial intelligence reading. We read all that documentation. It takes seconds. We put it in a dashboard that the judge is wanting to look at of how to present all this information. We have predictive analytics in there on the likelihood of addiction and others. And then the judge can spend most of his time looking at the child and their family rather than sifting through the paperwork. We're finding that it's making a very large difference in both the judge's ability to interact with the patient and how they're feeling about the judgments that they're and the care that they're giving for the child. So 3 stories: population health, intelligence, and how it will make a difference. Okay.
Dr. Pomerantz.
Almost 65 years ago, a New Zealand beekeeper and his Nepalese guide successfully reached the summit of Mount Everest. Prior to May 29th, 1953, many expeditions tried and failed, and occasionally with tragic loss of life. There's something deeply embedded in our souls that drives us to achieve seemingly unattainable goals. All of you sitting here today have collectively devoted your professional lives in the pursuit of helping and healing others. And now we ask that you add another duty to your cause, and that is to reasonably and ethically help decelerate the staggering medical cost increases that are straining all our budgets. Payers and supply chain partners have to work together, come together now, to bring innovative therapies faster to the market. So, breakthrough therapies. Some little review of history here. On the left, you'll see a box, a table with 4 examples: Turing Pharmaceuticals, Spark Therapeutics, Biogen, and Gilead. I'll talk about Turing and Gilead briefly. So in 2015, Turing acquires a 62-year-old anti-parasitic, antitoxoplasmosis drug, Daraprim, and virtually overnight raises the price 5,000%, from $13.50 a pill to $750 a pill. Gilead, you might be familiar with too, came to the market, now offering a cure for chronic hepatitis C, Sovaldi. Cost, when first released, $1,000 a pill, $84,000 for a 12-week treatment. Some of the rationale discussed in the media and about was that if you looked at the long-term costs of hepatitis C as a chronic illness, cirrhosis, liver failure, liver transplant, perhaps $84,000 is a reasonable price. But I would ask all of you to consider, after World War II, when penicillin became commercially available about 1948, did the pharmaceutical manufacturers look at penicillin and say, we're going to price it and benchmark it against end-stage rheumatic heart disease? Think of the availability of penicillin if that were the case for my grandparents, my parents, or even myself as a child growing up in the 60s. If we turn our attention to the right, you'll see a curve, and basically for any company involved in R&D, pharma, device, diagnostic, you'll see a fairly straightforward curve of investment period to product launch and return. And here's where we start talking about population health, is that most of the work, most of the analytics on value, where we understand cost per outcome, happens post-market. It happens in phase 4. It does not happen in phase 3. We are, as we should be, completely focused on safety, efficacy, and outcome, but not the financial implications, the development cost, the longitudinal cost in a community setting of what that therapy, diagnostic will bring or device will bring to the market. So I would ask you, why should we wait when these costs come in and start crippling our budgets? By way of reminder, and David mentioned this, but total health expenditure in 2016 in the United States, $3.3 trillion, 17.2% of gross domestic product. It's growing at a compound annual growth rate at over 5% from 2013 through 2016. So when we looked at this cost conundrum or crisis, we said, well, where's it coming from? And we rationalize this and very, very simply. If we think about it as a demand and supply curve, And we say to ourselves, will the demand for longer life, better health ever decrease? Will any of us ever desire less than that for ourselves or our children? And the answer was quickly no. So then the opportunity immediately went to, well, what does the supply chain look like? And certainly, as the chief medical officer of a large nonprofit Blue Cross in the United States, I said, let's look at the supply chain. And some of you are probably familiar with Don Berwick's paper in JAMA in 2012, where he looked at waste. And we looked at those 6 levers: pricing failures, overtreatment, and failure of care delivery, which comprise about 50%. And we said, if we can tackle these 3 levers and make a start here, perhaps we can start rationalizing our healthcare financing system. So we came up with 3 ideas, and you'll see a case study on them in a moment. But for pricing failures, we said, if there's a premium in the market for a new technology, a new therapy, shouldn't it come with not just the promise of a clinical outcome, but the guarantee of a clinical outcome, backed by a financial guarantee? For overtreatment, the problem is that when new products hit the market, there's still a lack of understanding about their application. And because a lot of the value assessment analysis is taking place as it's already in the market. So wouldn't it be helpful if we were already studying these new therapies, these new technologies in phase 3, in community-based settings, in population health settings that David and Deborah have spoken about? And although still work in very strictly controlled academic environments, work in community-based population health settings. And for failures of care delivery, we said that if we're working in community-based settings, naturally we'll begin to understand the barriers to adoption. And again, Don Berwick wrote a paper years ago in JAMA that said maybe it takes 17 years before the bench science, the randomized controlled trials really work their way into community-based standards of practice of medicine. I'm sure it's less than 17 years now. I hope it's not longer. But certainly, it's too long for where we are with technology and communication today. So you see at the bottom of the slide, the idea was establish a clinical outcome guarantee for pricing failures, bring market forces to bear, much like a consumer product warranty. Analyze the total medical cost in phase 3. Now, don't wait to phase 4, and do this in a population health environment. So here's the concept, the business model for the clinical guarantee. A provider, and I'll share with you a case study on the next slide. The provider is the Mayo Clinic. The supplier is Medtronic. The health plan is Blue Cross Blue Shield of Minnesota on behalf of the patient. And that's what you'll see in a moment. But the idea is that we would work with a supplier. We would look at a very specific outcome for a very specific cohort. And that supplier would say, we will guarantee that outcome. And we'll say, fine, we will agree to that. And we'll set the pricing. The doctor, the hospital will deliver that treatment, that service, that therapy. The hospital, the doctor bills us. We pay the claim. Everything goes on. However, in the case that there's a complication or failure of that clinical outcome, the supplier then reimburses the health insurance company. And here's the difference. Not just for the cost of the device or therapy itself, but for the entire longitudinal cost of care related to that defect or complication. So here's the case example. So TYRX. We've been working, and there's something about Medtronic probably in the water here, but we've been working with Medtronic too. And we didn't know that until we just spoke a few minutes ago. And we've been working with their visionary chairman, Omar Ishrak. And he approached us, and he said, we have a product, TYRX. And what it is, if you're not familiar with it, it's an antibiotic envelope or sleeve that external cardiac devices get inserted to before they're put into the chest wall. These devices are pacemakers and defibrillators most commonly. And in 1 to 4% of the time, even with rigorous antiseptic hygienic technique in the OR, there's an infection that follows. And when you have an infection and you're in a high-risk group, and the high-risk group would be early pocket reentry, high-voltage device, replacement of an existing external device, your mortality is as high as 50% at 3 years. It's high, it's staggering. And the average cost is in the high $50,000 range. That's not just the device replacement cost. That's the cost to pay for the surgeon, the hospital bed, the antibiotics, the cardiologist, the anesthesiologist, all post-acute care. Roughly per episode, it's in the high 50s. TYRX, if you're in that 4% or high risk group, reduces your risk to infection from 4% to 0.44%. It's a logarithmic reduction. So we were looking at the data, and we were talking to the hospitals and saying, why isn't this used more? And the answer was that, well, we pay the hospitals really one rate, like a diagnosis-related group in Medicare. We pay them a case rate. And most patients who come in for external cardiac device implantation do not need TYRX. It's only in the high-risk groups. So what we wanted to do is we wanted to say, well, can we build a business case and test it with you to start looking at new technologies and therapies in phase 3? We're going to do this with you in phase 4. It's an approved product. And why? Well, because of the relationships we have with Medtronic, with the Mayo Clinic, we need to reconfigure our claim engines to segregate these claims out because they're not approved yet. They're not evidence-based. They're still investigational experimental in phase 3, obviously. We want to see the impact would be on the doctors in terms of workflow, signaling us on the claim that this was an investigational therapy, so we can segregate it. Then we wanted to see if we could work with the supplier, and although we've agreed to this contract, would payment actually take place, and could we test it end-to-end, the whole cycle? So the idea was to create the model in phase 4, translate it, and then put it into phase 3, and bring it out to community-based population health settings that David is speaking about, and create a scalable model. We've begun enrolling patients this month, and we expect if we enroll between 135 and roughly in that range, we should see one infection. We don't want to, but the data says that that typically would happen. And then we want to see, did we accurately identify that patient? Did we communicate properly with Medtronic? Did we receive payment? And we believe this will start bringing market pressure to bear on manufacturers that come out with breakthrough products and saying, okay, back it up. And I think that will bring some rationality back to market pricing failures. Now, regarding overtreatment and failures of care delivery, for many of you in the room, you look at the top part of the graph, the top chevron, and you'll see the normal FDA process flow. Unmet medical need, you go through your clinical trials 1 through 3, FDA publishes a decision, and then the incremental cost analysis is taking place largely in phase 4, whether it's NICE at the NHS or ICER, Institute for Clinical and Economic Review in the United States. That's when they're doing a lot of their work. We're saying, let's translate that to phase 3. Let's work with population health community-based settings, because that's the real world, more for most of us. And then we can see what are the barriers to adoption, what are the total longitudinal costs of care, and we can understand value, cost per outcome. And then we can set up a rational pricing structure with the suppliers, so there's not this arduous prior authorization process. There's not this arduous, well, when does it move beyond the experimental investigation phase with you, health insurance company, whether you're Blue Cross or another company. And we start understanding value together. And I'm asking all of you as researchers, there's another duty for you here, and that's to work with us to start to understand value or the financial analysis during the phase 3 studies, pre-market, not waiting for post-market. So some policy positions that we've arrived at. We should begin the analysis of cost effectiveness looking at the longitudinal approach in phase 3. We should do this in community-based population health settings. We would also recommend that we shift from other intermediaries, and I won't mention who these publications are, but you're familiar with them. At hospitals, doctors, they seek them out, and some of them are quite good, obviously. But why don't we publish outcomes? Why aren't we publishing cost per outcome so we understand value? We understand transparency in every other part of business and industry. Why not in healthcare? And in the pricing model, if there's a large spike, what's considered traditional pricing, then back it up with a clinical guarantee that is basically a warranty on that. And finally, we feel this can only take place if all of us work together. We have the financial data, we have the utilization data. We want to marry that to all the clinical data, pre-market, prospectively, and create transparency. And I'm not here to suggest, cost plus fair margin equals the pricing and what the fair margin should be. but I'd like us to be part of that debate together, not just a health insurance company saying this is too costly, or a patient saying I can't afford this. But I think us, you in the room, your researchers, clinicians, leaders, join us in trying to start setting some pricing norms that can create a sustainable system for us. So I started with Everest. Let me finish with Everest. So you'll see Edmund Hillary and Tenzing Norgay here on the right. And what does Everest have to do with healthcare? It's a powerful historical example of how a unique collaboration conquered one of our greatest challenges. Hillary and Tenzing oftentimes were tethered by a short rope, and they saw themselves as one organic unit. And literally every step they took held each other's life in the balance. And they braved temperatures minus 50 degrees below zero, 70, 80 mile an hour winds, cycles of pitch darkness, and the physicians know in this room, oxygen tensions not fit for human survival at those heights. However, they never wavered in their belief that they would reach the summit. And we must never waver in our belief that we can create a rational provisioning of healthcare services that's fairly distributed and protects financially vulnerable populations. Every patient counts. Payers like myself, we must recognize that you, the scientists, the researchers, the clinicians will lead the way. And finally, I know Peter Diamandis is going to follow shortly on this panel. And he started this extraordinary conference with healthcare innovation during exponential times. And he spoke about quantum computing. And when he was talking, I was thinking about, I don't know why, but quantum mechanics and the century that we're in. And I thought about 1905. And some of you will know this, but it was the Annus Mirabilis, the year of miracles. This is when Albert Einstein published 4 papers about the photoelectric effect, Brownian motion, energy mass equivalence equals mc squared. And I was thinking, listening to Peter, this could be the century of miracles, not just the year, but the century. But only if we come together and build a rational, sustainable healthcare financing system. Thank you.
Glenn, thank you very much. So David, Glenn's asking, why aren't we publishing outcomes? And for population health intelligence, using your Largo, how is that applied in clinics today? You showed that fascinating image of 2 keys. They look like keys. They look like thermometers, actually, yeah, of where the money is going and where the actual value is.
Yeah. So this is a great presentation. So there's lots of compelling reasons we don't publish these kinds of things, but in our journal, we're very interested in exactly that, Mehmet, because it's that kind of information that we think is going to help decision makers reallocate resources to try to figure out how we'll get the best bang for the buck in terms of improving health. Let me give you an example. Kinds of things we're interested in is what school-based lunch program is working, what diabetes education program is working, what can we do to improve education to reduce opioid abuse. These are the kinds of programs that we're very interested in learning a lot more about. And it's not, generally speaking, in the kinds of journals that most leaders read.
Glenn, why not just give a money-back guarantee? I mean, I was looking at that example, but it's a very precise example for a complication rate that is remarkably low. So I can see the business motivation for Medtronic, but my father-in-law years ago said, he's a heart surgeon as well, why wouldn't we just offer to do any repeat procedures for the first year for free? You do. So there's not a downside. I don't have to pick up some cost I can't measure, right, but I will do everything for free after the first year if it's not working out.
Well, certainly we would be interested in that type of business construct. I think it's finding a willing provider at this point. But in fairness to the providers, this works best when the outcome is really binary. You have an infection, you don't have an infection. And there's not a lot of operator expertise. In other words, a supplier is willing to put that guarantee behind it because the operator expertise, it's almost routine that pacemaker device insertion can be done competently almost, in most settings. Also, it can't take, I'll say, unusual or extraordinary patient compliance in terms of the behavior required there. So we really can focus and segregate whether the device works, the antibiotic works, strictly to the technology of the therapy, as opposed to some other variable that could interfere with the outcome. So it has to be very tailored.
And Deborah, is population health intelligence accessible to the average clinician? I suspect some of the things that we've heard on the set are not that easily discernible for a lot of folks who are just in the salt mines taking care of patients.
You know, I obviously I work for a tech company, so I think population health intelligence is dependent upon having tools available to physicians on the front line. We do not have them. We do not have them widely distributed today, but every revolution takes a start. Every revolution takes the first people to start and the first apps to start. So I think within 5 years, they will be widely disseminated onto physicians' desks so that physicians really can help their patients in population health. And within 5 years, without a doubt, we will be looking at a 360 view of patients, including their zip code, including their credit score in a very HIPAA or privacy compliant way. Not there today, but we're starting.
Hey, Mehmet, I'll pick up on that. A great answer from Deb. So there are half a dozen new companies looking at trying to get this sort of population health intelligence information onto the doctor desktop so that you pop on the computer when we're in the office and it says, hey, there's a risk here that this patient's never going to come back. There's a risk that when you hospitalize this patient, they're going to be readmitted, and it's using all the population health data that we've been talking about both today and yesterday afternoon.
We have to not just give the data to folks, we have to train people to use the data.
You bet.
And I just want to understand where that is right now. Are medical schools or allied professionals getting exposed to this? Are there examples around the world where that's part of the process? Most of us learn. I remember I was in a lecture in anatomy class, my first year of medical school, and the dean got up, he interrupted the class, and he said, you know, just remember that half of what you learn in medical school will be proven wrong by the time you finish your practice.
Yeah,
the only problem is you don't know which half.
Right.
And I think every medical student hears that. And so it becomes a frustrating reality that we're outdated by the time we graduated.
So I'm going to take this one first and give it to Deb. So first of all, you know, being at this amazing conference, I was speaking with some of the leaders yesterday. Mehmet, for you and me, our genetics textbook from medical school would make like a great doorstop or, you know, kindling wood to get a fire started, since all the dramatic changes due in part to some of the people who are sitting here, right? So, you know, it's moving at an incredible pace. We believe that online graduate level education, excuse me, in these kinds of issues is what is behind launching our College of Population Health. One school is not going to change the world. 10 schools that have been built since we opened our doors, well, that's a movement. And then creating other new medical schools, Hackensack, our colleagues who were up here just before us, now we're starting to get traction. So since this whole morning is about education and Robin's kickoff comments, I think this is the beginning of a movement to put this sort of material into the curriculum, not just in medical schools for sure. This has to be across all the health professions.
The new medical schools that are being built, I think the majority of them are thinking about how artificial intelligence and big data fits into the curriculum and how to teach physicians to use it. And the established medical schools are also thinking about, okay, this is here now. This is going to help augment intelligence. How do we put it into the curriculum? Yeah.
Indeed.
And why do we delegate this all to the clinicians? Much of what, David, you showed in that earlier slide is material that patients should be driving.
Right.
And I've always believed that there was sort of an 80-20 rule in healthcare. It's one of the reasons I think we have major challenges when folks try to offer government plans. 80% of people can get out of their own way, can manage their own health care pretty efficiently if they're given the information they need. They can manage the money that they're going to spend. For them, health savings accounts might make a lot of sense. 20% of people, Deb, you picked up a group, you know, folks who are having mental health issues, opiate addiction, other societal variables that just make it hard for them to do what's in their best interest. They need a little bit more hand-holding. Some might even call it a paternalistic approach, but you don't want to let them just go out there and flounder because they don't know how to swim in the water of healthcare. So how do we pick out who's who, give folks information, not just the information for their health, but the information they can use based on their ability to address their problems?
You want to take that? Yeah. No,
Yeah, you know, so we actually, IBM does health and human services programs for 170 million people in 22 countries. And, you know, we always did traditional health and human services programs. Here's the traditional amount of money that you get for food, that you get for rent, that you get for behavioral health issues. And what we're finding now is that really you might not be able to go drive to the pharmacy to get your medication, or you might miss your wellness appointment because you can't drive there, or behavioral health issues really are taking 50% of your time and keeping you from being as compliant as you can. So now we are arming care managers with actually artificial intelligence and showing them the whole person. We're finding, we just implemented in Harrow Council in London, and we're finding the care managers are saying, oh my gosh, I've been taking care of this person for 18 years, and I didn't know this information about them. And just being able to bring to the surface the information about the total person and what they're dealing with, we're finding better care plans for them, and the care managers are able to take better care of them. So we're at the very beginning. We are at the very beginning of being able to integrate all the information about the person that needs to be integrated. But when we get this wide scale, we're going to make quite a difference in helping people, you know, wholly. Do you need a ramp to get down? Do you need an Uber? What do you need for optimal health?
Mehmet, there are a slew of brand new primary care for-profit practices, franchise models, and we're not here to advertise them, but I think they have the approach that Deb is describing. They start their day asking the question, what patients aren't here who need to be? Instead of you know, Glenn and I are primary care doctors, getting handed your list in the morning and go through it. They have a team meeting with the nurses, the case managers, and they say, well, who's sick, who's not here? And then that changes the whole model. But that means you've got to have the infrastructure, the organization, the information to say, well, how many patients do we have who have diabetes, who have heart failure, who have other chronic illnesses? How are they doing? Who's the sickest, as you alluded to? What small percentage are driving the most cost? And then are we doing everything we can for those patients? I also think we're in a new era. Emmett, you're part of the lead of this, right? Getting better information out to people, led by our colleagues, Eric Topol, Bob Wachter, and others who are, hey, let's get everybody engaged. It's the democratization of the information. That's a big part of what this whole conference is all about.
Glenn, how do you see insurance companies working with patients themselves? One of the biggest complaints I will often hear is I can't get approved for that. Even what's being approved is pretty much in the best interest of everyone involved in the cycle. I'm just curious how those decisions get adjusted or educated by, just speak for all insurance companies, not just Blue Cross of Minnesota.
Well, for the very complex and costly procedures, tests or diagnostics, as Mehmet said, there's a prior authorization process where the physician submits, you know, clinical information, and it's adjudicated against, we have what are called medical policies. And then a decision's made to approve payment or not approve payment, and then if it's denied, there's an approval process that is undertaken. The idea here is that this has created a tremendous burden for physicians. And I myself, when I was practicing, was not terribly fond of it, and now I administer it. So I can tell you that the goal we have, as much as we need to, you know, look at and deal with these staggering cost increases and put together a budget and make premiums affordable for all of us, myself, my wife, my children, we need to deconstruct it in the right way. So there are these programs that we're beginning to develop in Minnesota, and I think other insurance companies will do this too, but to gold card is a term that's popular right now in the industry. For the physicians, the hospitals, the allied health professionals that are practicing evidence-based medicine, we should get out of the way, and we should look at their historical experience and then perhaps do an audit, you know, every so often to make sure they're still functioning at that high level, whether it's 4 sigma or 3 sigma, I'm not quite, you know, 95% or so 4 sigma, but we need to make it easier. So it is a big burden right now. We know it, and we have to work with the doctors and hospitals to change it.
Let me thank the panelists very much. Very nicely done.